This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco from the Cleveland Clinic, here with Sumanth, Reddy, and Jeff Gelfand to discuss their article published in N2, Biopsy-Confirmed Small Vessel Primary CNS Vasculitis, Clinical Features, and Impact of Early Intensive Treatment on Remission. Sumanth and Jeff both work at the University of California, San Francisco, and we really appreciate them joining today to talk about a really challenging condition. Hello and welcome.
Thanks for having us, Justin. It's great to be here.
Thanks for having us.
Sumanth, what were the major takeaways from this work?
There are two main takeaways we wanted to share. The first is that the clinical spectrum of small vessel primary CNS vasculitis is actually really diverse, not just in terms of the clinical and radiographic presentation, but also in terms of what areas of the central nervous system are impacted, what the disease course looks like, and how patients respond to treatment. The second big takeaway is that after treatment initiation, time to remission was significantly shorter among patients who received early treatment with cyclophosphamide. And this is in comparison to patients who received less aggressive treatment approaches up front, such as glucocorticoids as monotherapy or in conjunction with traditional steroid-sparing immunosuppressants, such as azathioprine.
So a really hard diagnosis to make, especially if we were just looking at some of these non-specific clinical signs. But I think we're going to take away a few pearls as we dive into this. And then we're seeing some benefit to early aggressive therapy, especially with cyclophosphamide in this population. Can you tell us how you chose your cohort? You really focus on biopsy-proven cases, and again, on just a small vessel cohort in a really rare disease space. Can you help us understand your logic and how you thought there were some gaps in the literature?
This series includes patients that had biopsy confirmation of small vessel CNS vasculitis. 100% of the patients we analyzed had biopsy confirmation, and we could be very confident in the biology and the pathology of the disease. Other approaches to vasculitis studies include patients who sometimes do not have biopsy confirmation, but may have evidence of vasculitis through other diagnostics, such as conventional angiography. But inherently, conventional angiography can see changes in large and medium-sized vessels and is not sensitive to the small vessel vasculitis inflammation that biopsy evaluates. Furthermore, clinical experience and emerging literature suggests that there are important differences in the clinical presentations and phenotypes, the disease course, and even the response to treatment among patients with small vessel involvement of CNS vasculitis compared to large or medium vessel involvement. And lumping these entities together has historically led to an approach of what we believe are likely to be different biologies or different immunological dysregulations that can converge and encompass various forms of CNS-specific vascular injury that we call vasculitis, but may ultimately reflect different diseases or pathogeneses. And by analyzing small vessel CNS vasculitis, this reflects the clinical entry point of phenotype that neurologists routinely struggle with and will use brain biopsy to diagnose. And then hopefully with analyses like this data set, we'll also be able to have more specific guidance about outcomes and treatment.
In your introduction, you did such a nice job talking about rheumatology does this all the time, right? They organize their vasculitis syndromes into these buckets and then applying that same logic here, especially for a really challenging disease like small vessel primary vasculitis. Sumanth, how did this cohort initially present? What were those initial CSF, MRI findings? What can we look for when we're on a hospital service, when we're in the outpatient clinic, that we should be like, we need to think about this entity?
So most patients present with days to week of headache and altered mental status, and about half of them will have seizures during the disease course. And during the workup, all of the patients in our cohort had T2 flare parenchymal lesions. And although the majority of these were enhancing on post-contrast imaging, about 10% never showed abnormal enhancement on MRI. Similarly, although the majority had a mild lymphocytic pleocytosis on CSF analysis, there were a significant minority, 1 in 5, that didn't actually have any abnormalities on their CSF profile. So this includes an absence of oligoclonal bands and a normal IgG index. There are a couple other cohorts I wanted to point out. There were a couple patients that had isolated unihemispheric disease that was relapsing in nature. This is something that's previously been reported in the literature. And about 10% of patients, similar to what's been previously reported, have spinal disease. And we noticed that these patients tended to be more resistant to treatment. Going off of what Jeff was just talking about, the important differences between large and small vessel primary CNS vasculitis, we really didn't see a large number of patients that had stroke. It was really uncommon to have sudden onset neurologic symptoms along with DWI lesions. And alongside that, it was very uncommon to see large and medium vessel involvement, beating, vessel irregularity, vessel wall enhancement on MRI, further emphasizing that small vessel primary CNS vasculitis and large vessel are probably distinct entities, or at least opposite ends of this clinical spectrum. I also wanted to point out that a subset of the patients, about a third of the patients in this cohort, were diagnosed with amyloid beta-related angiitis, or ABRA. Now, this is a form of small vessel primary CNS vasculitis in which the inflammation is centered around beta amyloid deposits that occur in the cortical vessels. So when we think about cerebral amyloid angiopathy, the condition in which these beta amyloid deposits occur in these cortical vessels, and primary CNS vasculitis, the overlap of that Venn diagram is ABRA. Now, these patients demonstrated a very similar degree of clinical heterogeneity, but there were 3 important differences. The disease was limited to the hemispheres, it occurred in older patients, and there was a predominance of leptomeningeal enhancement rather than parenchymal enhancement. It's just really important to keep an open mind regarding this diagnosis and to consider the role of biopsy to clinch the diagnosis when patients present with these constellations of findings and the diagnosis remains elusive despite extensive testing.
I really appreciate that breakdown so we can think about these things. And that point you made about the lack of stroke, the lack of vessel wall changes. You included CTA, you included MRA imaging along with DSA, and we're not seeing those abnormalities there. And so making sure that we have a high index of suspicion and not just using those clues to test or think about this diagnosis is so important. And then I do appreciate those comments about ABRA, which is a really rare entity, but have to differentiate that. And some of those clues with older disease, leptomeningeal disease, I think are some real important pieces. Jeff, maybe you could talk about this. I know Sumanth just mentioned it, right? This is a disease that usually requires biopsy. What would be some keys that we could look at on a pathology report or discussing with our pathology team and to make sure that we have the diagnosis correct?
In supporting a diagnosis of primary CNS vasculitis, it's critical for the treating neurologist to work closely with our neuropathology colleagues to understand and review the pathology and to make sure that the pathology is consistent and correlates clinically so that we can best diagnose and care for the patient. The key thing is to make sure that it's actually a vasculitis on pathology, and specifically that there's inflammation in the vessel wall intramurally, typically with disruption and destruction of the vessel wall architecture. That's the vasculitis component. And that's in contrast to perivascular inflammation, which is much more typical of broader neuroinflammatory processes that aren't necessarily vasculitis. The key thing here is to make sure there's actually vessel wall involvement. Additionally, the literature primarily refers to descriptive subtypes of the inflammation and patterns of vessel wall destruction. For example, terming lymphocytic CNS vasculitis, that's small vessel, or granulomatous inflammation, whether or not there's necrosis, and also whether or not there's the presence of amyloid. There can be additional heterogeneity neuropathologically when looking closer, including mixed infiltrates. It's likely that there's going to be additional precision and individualized signatures of the types of inflammations that lead to the final common pathway of what we call descriptively and pathologically a small vessel CNS vasculitis. Clinically, it's also essential to correlate the pathology findings to exclude a secondary vasculitis, in particular from an infection that can cause a vasculitis or neoplasm or a cancer. And that's really up to the neurologist to do the clinical due diligence before we make the final determination that it's a primary CNS vasculitis.
I don't know if I've ever gotten a report back and you feel really confident about the diagnosis. It really does require that conversation with the pathologist to make sure. And I heard these elements, right? Inflammation with the vessel wall is key in ruling out some potential mimics. I think you also noticed some relationship between some non-diagnostic pathology results in patients who are receiving glucocorticoids. Can you talk about that relationship and how we should think about the timing of biopsy with potential treatment?
A subset of patients in our data set underwent repeat brain biopsy because their first brain biopsy was non-diagnostic. Of those, patients who had received glucocorticoid steroids within 2 weeks of the biopsy had a higher rate of the biopsy being non-diagnostic. This supports other literature and clinical experience that it's optimal to time biopsies when patients are not on glucocorticoids, not on steroids, and have been off glucocorticoids for a substantial or decent amount of time to increase the rate of a diagnostic biopsy, while of course balancing clinical benefit and risk.
It's not always easy. Patients are really sick. But if we can think about this and try to make sure that we have a clean sample for pathology to look at because of its importance in this diagnosis, it's a really helpful reminder. Sumanth defined early intensive treatment with cyclophosphamide as that being initiated within 3 months and then continued for a few months thereafter, versus this escalation treatment group who were consisted of patients mainly with glucocorticosteroids plus or minus oral medications. I think you mentioned azathioprine, mycophenolate, methotrexate. What trends did you see when you compared these two cohorts?
Justin, I think it's fair to say most neurologists have prescribed cyclophosphamide sparingly, if at all. And so I just wanted to briefly discuss the rationale for why we chose this. Cyclophosphamide has been around in the rheumatology world for decades, especially for conditions such as ANCA-associated vasculitis. And the data there is quite strong. It shows that patients treated with cyclophosphamide achieve remission sooner. There's a lower risk of mortality. There's a lower risk of end organ complications. And so many neurologists and rheumatologists have extrapolated this to say that cyclophosphamide should be standard of care for patients who have small vessel primary CNS vasculitis. On the other hand, given the toxicity concerns of cyclophosphamide, others say that maybe we should only reserve cyclophosphamide if less aggressive treatment approaches are unsuccessful. So if a patient doesn't respond to steroids, plus or minus the medications that you mentioned, then maybe we escalate to cyclophosphamide. But in our study, we found that the time to remission was 14 months shorter, so over a year shorter among patients who received early intensive treatment with cyclophosphamide. And there was also a trend towards lower cumulative glucocorticoid exposure. And at 2-year follow-up, half of the patients in the early intensive treatment group had a functional improvement, so at least a point improvement in their modified Rankin scale, compared to just 36% in the escalation group. I think it's really important that future prospective studies look into these long-term treatment outcomes in a little bit more detail as well, so that we get a better sense of what is the true impact in terms of long-term functional outcomes of early intensive treatment with medications such as cyclophosphamide.
I appreciate that background. I agree. Addressing the elephant in the room a little bit. I think cyclophosphamide can be a little scary, though. When we're talking about it in IV formulation for shorter periods of time, I think we have some good safety data and then relying on our rheumatology colleagues that can help us there. I appreciate that. But some really dramatic differences. We're dealing with small numbers, but this is a really rare disease. And so I think still helpful to at least give us some paradigm on how to approach these cases. Maybe a related question, and one that seems simple, but I don't think is well defined in the literature, is how we even define success, remission, and how we approach after that initial treatment. Jeff, do you have thoughts on how you do that now in clinic?
Cyclophosphamide is sometimes very practically harder to organize and harder to actualize logistically for patients in clinical practice. For neurologists who are very comfortable prescribing cyclophosphamide, whether IV in pulse dose form, typically every several weeks, versus daily oral cyclophosphamide, there's different regimens that can be considered. Neurologists will often take lead in prescribing. But if neurologists are less familiar or don't have the infrastructure set up to safely monitor cyclophosphamide, it can be very helpful to partner with colleagues in rheumatology or oncology or other specialties who routinely prescribe such medications. And in our analysis, we also wanted to look at the practical sides to delays in actualizing or delivering cyclophosphamide therapy. And I think one of the takeaways from this paper is that earlier induction treatment with cyclophosphamide, when it can be sustained and delivered safely, led to better outcomes. And so it's really important for neurologists to become familiar with the prescribing and safety with this medication and to come up with systems to be able to deliver this medication in a timely fashion within their local healthcare system.
I love the idea of partnering with folks if you don't use this medication as often, because rheumatology, oncology, they use these medications frequently and can help make sure it's being dosed correctly and the monitoring parameters are in place. One point that you just made there is like, how do we even define success, remission? How do we approach after that induction course? What did you find in this work?
We defined remission as clinical stability or improvement. In other words, no new or worsening neurological symptoms that are potentially attributable to the vasculitis, to the primary CNS vasculitis, and no evidence of new or worsening imaging abnormalities, such as new diffusion abnormalities, hemorrhage, abnormal enhancement, or other new MRI lesions or expanding lesions. In other words, there should be no evidence of further clinical or MRI activity from the vasculitis. Additionally, spinal fluid can be a helpful adjunct, and we did observe that in patients who had oligoclonal bands, for example, when the vasculitis was active, in a subset of patients where there was follow-up CSF testing, there was interval normalization, resolution of the bands. Essentially, the spinal fluid normalizes in support of remission as well. And this suggests that clinically, spinal fluid could also be an important adjunct, especially if there's questions or disconnects between the clinical and imaging picture. So in other words, the goal when treating vasculitis patients is to put the process into remission so that there's no normal or active inflammation and no new damage, and then to try to maintain that remission for a period of time while weighing the risk and benefit of ongoing immune treatment.
Sumanth, maybe you can help wrap it up for us. After doing this work, really diving into this data, how are you going to approach clinical care moving forward? What are you going to tell your colleagues on these really challenging cases?
We hope that this work emphasizes the need to be attuned to small vessel primary CNS vasculitis as a diagnostic possibility when there are unexplained findings such as unexplained enhancement or hemorrhage, particularly when the diagnosis remains uncertain despite extensive testing. We also want to underscore the importance of the fact that a normal angiography and a normal CSF profile does not rule this disease out. This is also one of those conditions that really emphasizes the importance of CNS biopsy as a diagnostic tool for neurologists. We also hope that this work has neurologists strongly considering cyclophosphamide as soon as the diagnosis of small vessel primary CNS vasculitis is confirmed via biopsy.
I think it's such a good summary. Again, this is a disease that keeps me up at night, right? Have we missed it? You do a biopsy, it's non-diagnostic. It's such a challenging disease to put your finger on, but your work helps emphasize some really important points. I love those points that if we're just looking for stroke, we're going to miss these cases. And I also love the point you made, not only about this early aggressive treatment, but then some markers that we can use to help make sure that patients are truly in remission and we're doing everything we can for them. So with that, I appreciate you guys joining us today, going over hard disorder.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.